Hey folks, this is your short lecture for Chapter 17 that covers death, dying, and grieving. It is quite short, so hang on for that. This is our last lecture together, so that is something for you guys to celebrate. Let's go ahead and get started. As we are looking through this chapter, in your chapter reflection, I'm going to have you guys give me 4 paragraphs, one covering each of the following topics: defining death and life-death issues, a paragraph about a developmental perspective on death, a paragraph on facing one's own death, and then your last paragraph, coping with the death of someone else. As we jump in here, we can see that issues in determining death, we see that brain death is defined as when all the electrical activity of the brain has ceased for a specified period of time. A flat EGG reading for a specified period of time is one criteria of brain death. It includes both higher cortical functions and lower brainstem functions. When we are looking into advanced care planning, that's a process that patients take about thinking about and communicating their preferences about end-of-life care. And there is some choice in dying when it comes to creating a living will. That is a legal document that reflects the patient's advanced care planning. An advance directive indicates whether life-sustaining procedures should or should not be used to prolong an individual's life when death is imminent. You might have heard of something called euthanasia, and that's the act of painlessly ending the lives of individuals suffering from incurable diseases over severe disabilities. We have different forms of euthanasia. Passive euthanasia is a treatment, is the treatment of the patient is withheld. Active euthanasia is death deliberately induced. And then there is also something known as assisted suicide, and that is the patient self-administers lethal medication and determines when and where to do this. We do know that there is needed for better care for dying individuals. Death in America is lonely, prolonged, and painful, and a good death involves physical comfort, support from loved ones, acceptance, and appropriate medical care. When we are looking into parts of dying that can reduce some of the pain and the stress, we look at hospice. That's a program committed to making end of life as free from pain, anxiety, and depression as possible. And this includes something called palliative care, and that's reducing pain and suffering, and it's helping individuals die with dignity. We know some things about facing one's own death, specifically knowledge of death's inevitability permits us to establish priorities and structure our time. There are 3 areas of concern, though. Privacy and autonomy is in regard to their families. Inadequate information about physical changes and medication as death approaches, and motivation to shorten their life are 3 of some of the areas of concern. We can look at the stages of dying that the text talks about, and we can see that we can begin with denial and isolation. Often a dying person denies that they are really going to die. That moves into anger, and that is when the dying person's denial gives way to anger, resentment, rage, and envy. The 3rd stage is bargaining. This person develops hope that death can be postponed, followed by depression, and that often looks like the person withdrawing, crying, grieving. The dying person comes to accept the certainty of death, and that follows acceptance and that sense of peace that you may have seen someone going through this process experience. Perceived control may be an adaptive strategy for remaining alert and cheerful. And then there's also denial, can insulate and allow one to avoid coping with intense feelings of anger and hurt. We know that more than 80% of Americans die in hospitals. Nearly 20% of Americans die in nursing homes. And hospitals offer many important advantages, including professional staff members, technology helps prolong the life. But we also know that most people would rather die at home. So those numbers are kind of sad. When we are communicating with a dying person, we know that open communication is important because they can close their lives in accord with their own ideas about proper dying. They can give their own input. They may be able to complete plans and projects and make arrangements and decisions before their time has passed. They have the opportunity to reminisce and converse with others, and they have better understanding of what is happening to them if we continue to communicate with a dying person. When we're looking at grieving, dimensions of grieving include grief. It's emotional numbness, disbelief, separation anxiety, despair, sadness, and loneliness accompanying the loss of someone loved. Pining or yearning reflects an intermittent, recurrent wish or need to recover the lost person. There are cognitive factors that are involved in the severity of grief. And there is also something that's mentioned about prolonged grief disorder. Disenfranchised grief is an individual's grief involving a deceased person that is socially ambiguous, lost, and cannot be openly mourned or supported. Maybe like an ex-spouse, an abortion, those type of thing have been stigmatized. Coping and type of death. The death's impact on survivors strongly influenced by death circumstances. Sudden deaths are likely have more intense and prolonged effect on the survivors. And those survivors may even develop post-traumatic stress disorder from an intense sudden death of a loved one. Making sense of the world. Grieving stimulates individuals to try to make sense of their world. Reliving events leading to the death is common. When death is caused by an accident or disaster, the effort to make sense of it is even more vigorous and important to those left surviving. When we talk about losing a life partner, the death of an intimate partner brings profound grief. Widows outnumber widowers because women typically live longer than men. Age groups and percent of widows, there are about 14% of 65 to 74-year-olds are widows, 31% of 75 to 84-year-olds, and about 59% of those 85 and older are also widows. Widowed women are probably the poorest group in America. Many widows are lonely and benefit considerably from social support. We also know that cross-cultural study of widowed men and women gave us information about there was a study in the U.S., England, Europe, Korea, and China. The depression peaked in the first year of widowhood for men and women. Widowed women recovered to levels compared to married individuals in all countries. Widowed men continue to have high levels of depression, 6 to 10 years post-widowed everywhere except in Europe. And becoming widowed is associated with a 48% increase in having an earlier death. There are different forms of mourning that we know about. Funerals are an important aspect of mourning, and cultures vary in how they practice mourning. But specifically in the U.S., funerals are conducted privately and then are followed by a memorial ceremony typically. In some cultures, a ceremonial meal is shared after a death, while some others will have a black armband that they wear. That's worn by the bereaved family for 1 year following the death. In the Amish culture here in the United States, community handles virtually all aspects of the funeral. I appreciate you guys listening to this short lecture. It was definitely an encouraging lecture, but it's something that's important for us to know and to understand. As always, if you guys have any questions, please reach out to me and I will get back to you as soon as I can.